I know it's hard when we wear dresses.
Dresses with no pockets.
With no pockets. They don't design them for women.
Good morning. It's nice to see you all here. Nice to be giving a presentation to live people in the same room and not just on Zoom. Last semester, I was very lucky. My students the previous year, the whole thing was remote, and this year we were back live. Similar to this, where the first 2 rows, nobody got to sit so that I could speak without a mask. And so we had to be about 10 feet apart at the front. And we're starting this semester with the first 2 weeks remote, and then we're going to see from there. So hopefully they will get back in the classroom maybe by February. So just a little bit of background about myself. I have been at University of Colorado for about 14 years or so, practicing in the endocrinology clinic at University of Colorado Hospital, managing diabetes primarily. So some other endocrine things here and there, but primarily diabetes management for a lot of patients with type 1 diabetes, a lot of patients with complex type 2 diabetes. And then I teach in the pharmacy school as well. So before that, I was in Boston for 10 years. I was at Northeastern University at the School of Pharmacy, and I was practicing at Brigham and Women's Hospital there. So I am very passionate about diabetes. I have a lot of really amazing patients that know a lot about their disease. Everything doing okay? Yeah. Oh yeah, thanks. Perfect, thank you. So yeah, I'm happy to be here. So I think I read the roster. It looks like primary care, lots of people in primary care, a mix of docs, nurse practitioners. Are there any PAs here? Any pharmacists? Hello. Okay, great. So we've got all sorts of stuff. I could talk about diabetes for days, but I will cram it into 5 hours and get you out of here on time so you can enjoy this beautiful weather. What I was planning on doing was I'm going to start off with just a review of all of the medication classes, the new evidence, a little bit about some of the pathophysiology of the complications surrounding diabetes. We'll talk about the meds. We'll spend a lot of time talking about the new medications and the evidence that we have to support their use. And then I'll tell you about the guideline recommendations of how we should use those medications to treat type 2 diabetes. And then we'll work through some patient cases together. We'll talk about insulin a little bit as well. And then the last part, we'll talk about kind of what's new with technology. So continuous glucose monitors are making their way definitely into primary care practice. So I wanted to spend a little time about talking about what the different products are, how they can be used by patients, and then how you can use the information to identify patterns with glucose and how you could change therapy based on those patterns. Sound good? Sound good. Okay, any questions for me before we get started? Okay. Hopefully everything I just said made its way into the learning objectives. I think that they did. All right. So of course, diabetes is a huge problem. We all know this. This is not a mystery. The numbers, every time the CDC comes out with a new stats sheet, I have to update the numbers and they just increase every time. So we've got a lot of people in the United States with diabetes. And a ton more that have prediabetes. So they're on their way to developing if we don't make any changes to lifestyle or things like that. It's also, of course, a global emergency. We're seeing the rates of type 2 diabetes increase quite a bit in other parts of the world as well. That feels like a big echo now. Is that okay? Okay. So it sounds a little. I don't want to blow you guys out. Is that good? Okay. Okay, so I think we all know these things too. So diabetes is a very high leading cause of death in the United States. It increases the chance of kidney failure, amputations, blindness, major cause of cardiovascular disease, so high rates of stroke, myocardial infarction. We're also seeing increased prevalence in certain patient populations, so African Americans, Hispanics, kids. So we're seeing a lot more type 2 diabetes diagnosed in young folks because the rates of overweight and obesity are increasing in all populations, and that included. And we know that the rate of death is about twice that of people that don't have diabetes. So lots of reasons to care and to try to manage diabetes a little bit better. Complications, of course, are typically categorized as macrovascular, large vessels versus microvascular. So we've got cardiovascular disease, peripheral vascular disease, stroke, and then we have all the microvascular complications as well. So we've got diabetic kidney disease, we've got retinopathy, and then we have neuropathy. So either peripheral neuropathy or autonomic neuropathy. So this is why we care about controlling glucose. If we control glucose reasonably well, we have a really high chance of preventing those complications from happening. And I think I mentioned that on a previous slide. So I wanted to spend, because there's so much data coming out with the new medications related to some of these complications, I wanted to spend just a few minutes talking about those complications in just a little bit more detail. So first of all, what's the relationship between diabetes and cardiovascular disease? So long-standing hyperglycemia increases the chance of cardiovascular disease by twofold. The reason is there's a combination. So all that extra glucose in the blood vessels leads to damage in those blood vessels because you've got impairment in nitric oxide, so you've got endothelial dysfunction. You've also got platelet activation and aggregation going on from that increase in glucose in the blood vessels. And then you can have changes just in the plaque character. So longstanding hyperglycemia ends up causing all that damage to the large blood vessels, increasing the rates of cardiovascular disease. Another complication that actually wasn't on the previous slide, because is it a complication? Is it a comorbidity? What's the relationship? We're not quite sure. We're still learning about that. But something that's overlooked is this relationship between diabetes and heart failure. So we know that people with diabetes are much more likely to have heart failure. If you look at people who are hospitalized for heart failure, a very large portion of them have diabetes. So like 44%. I told you in a previous slide, about 10% of the general population has diabetes. But if you're looking at just the folks that are hospitalized with heart failure, 44% of them have diabetes. So we know that there's some correlation there. We also know that people that have diabetes do worse. So if they do have heart failure, their outcomes are worse than people that don't have diabetes. So what is that relationship? What is that correlation? Part of it is just that they share some similar risks. So diabetes increases the chance of cardiovascular disease. Cardiovascular disease in and of itself leads to heart failure. So that's one just correlation right there. But then there's also some just common risk factors between the two disease states. Hypertension is probably the biggest. So most people with type 2 diabetes also have high blood pressure. High blood pressure is a very known reason for people to get heart failure. So just those shared risks alone explain part of that correlation between diabetes and heart failure. But there's also some direct issues going on too. So hyperglycemia leads to AGEs, advanced glycation end products, which are very damaging to the blood vessels. You also have all of these other pathophysiologic issues going on from that chronic long-standing hyperglycemia. So a lot of direct effects to the myocytes, along with these kind of shared risk factors. So why am I bringing this up? Because we're hearing a lot about diabetes and heart failure together. Why? Because now we have some drugs that have shown to decrease the risk of both of those things. And so as always, when drug companies come out with new drugs that have these great outcomes, you start to see a lot more information popping up about the relationship and the pathophysiology and things like that. So there are a lot of new review articles and studies coming out kind of demonstrating what that risk between hyperglycemia and heart failure is, but it's both shared risk factors along with some things that they're learning about direct effects. And that's the same thing. We're also seeing, I'm going to actually start with this one. We're also seeing a lot about the correlation or the dynamic between diabetes and the kidney. So we know nephropathy is a common microvascular complication of longstanding hyperglycemia. We're learning a lot more about why that is. Again, because we've got some medications that protect the kidney on top of lowering blood sugar. So there are kind of 4 big reasons why diabetes is impacting the kidney negatively. The first one on the top left are metabolic factors. So we've got these AGEs, these advanced glycation end products that come from longstanding hyperglycemia that directly damage the glomerulus of the kidney. We also have hemodynamic factors. This is probably what we think about the most in terms of what we learned early on back in the day about diabetes and the kidney, where you start to see issues with both the efferent arterial and the afferent arterial in terms of increasing that pressure within the glomerulus, which leads to damage to the membrane of that glomerulus. So those first 2, I think we know a lot about. We're also learning that there are some increases in growth factors happening from longstanding hyperglycemia, which are leading to damage to the membrane and the glomerulus as well. And then we have the pro-inflammatory and pro-fibrotic factors as well. And I'm not going to go into detail about all of those things, but we certainly know that hyperglycemia leads to prothrombotic state, increase in fibrosis. And so all of this pathophysiology together is what's leading to that kidney damage from diabetes. So let me go back to this first one. And so I think this is that hemodynamic aspect of it. On the left is a normal kidney, on the right is what you see with diabetes. And you can see here, you get this increased pressure because you've got the vasoconstriction here and you've got vasodilation here, which leads to this increased pressure within the glomerulus. Why is that important? Because we've got ACE inhibitors that work at one, and now we've got some diabetes medications that work at the other, and now we're using them in combination to really try to decrease that hyperfiltration and decrease that pressure in the glomerulus. So we've been using ACE inhibitors and ARBs forever to try to manage that. Now we've got another category of medications that we can add on to that to work at the other, the afferent arterial to work at decreasing that pressure as well. So important just to remind ourselves about what chronic kidney disease or diabetic kidney disease, how we kind of identify that, how we define that. So we're looking both at the eGFR as well as albuminuria. So getting that UACR or urinary albumin to creatinine ratio that should be ordered once a year or more frequently in people that have diabetes. And so we're identifying chronic kidney disease by looking at both of those. So eGFR, normal or high greater than 90, and then albuminuria, we're looking at anything over 30 would be a positive number. Anything over 300 is severely increased. We used to call that microalbuminuria and macroalbuminuria, and now it's all just albuminuria, even though they are categorized different. So as you go from green to yellow to orange to red, your risk of dialysis or end-stage kidney disease increases. So if your eGFR is high and your albuminuria is normal, your kidneys are functioning great, you have a low risk. As either of those go up, so maybe your eGFR is still fine, but you start to develop albuminuria, your risk is increased. If you don't have albuminuria, but your eGFR is going down, your risk is increased. If both of those things are abnormal, your risk is greatly increased. This is also just important to remember clinically because it helps us identify which patients really qualify for medication therapy. So we're not putting everybody. So if you're here and your eGFR is normal and you don't have any albuminuria, we don't put every single person on an ACE inhibitor to prevent chronic kidney disease. We don't have evidence to support that we need to add a medication in that situation. But as you work your way down, then you should be thinking about adding medications like ACE inhibitors and ARBs, and now some of these newer medications for diabetes. Okay, so managing diabetes, I guess basically my whole point of all of those slides was to illustrate that managing diabetes now is not just about glucose. So, for a long, long time, the ADA guidelines and other guidelines really focused on glucose. We look at the A1C, we're just thinking about which medications lower glucose. That's our marker. That's what we hear about. We're going to use the meds that can do that the easiest way. And we're not practicing that way anymore. Now we're using medications thinking about not only what can these medications do for glucose, but what can they do for all of these other things like heart failure, cardiovascular disease, kidney disease, and weight, and all these other things. Any questions about any of that information? All right, so let's talk about the meds. My favorite part as a pharmacist. Of course, we can put people on 1, 2, 3, 4, 5 meds, intensive insulin. If they don't change their lifestyle, it's very, very difficult to achieve glucose control and maintain glucose control for the lifetime. So I don't want to underemphasize lifestyle modifications. That is the key. Weight loss, carb control, physical activity. Those are the things that really manage type 2 diabetes. But I'm a pharmacist, and I think you're here to learn about the medications. So we're going to spend a lot of time talking about the medications. Don't think for a minute that means that I don't strongly believe in encouraging people to change their lifestyle and to lose weight and to be healthier. And it's a big part of my patient visit, every single visit. But let's focus on all these meds because there are a lot of them. And it used to be more straightforward. So you put people on metformin, you bring them back, you stick them on a sulfonylurea, you bring them back, you put them on insulin, and you see where you shake out. And now it's just more complicated because we have more meds and we have a lot more evidence. Okay, so we're just doing straw polls here. We don't have any clickers, but one of the things that I mentioned in this box is there's a lot of things to think about. What's the impact on cardiovascular disease, on heart failure, on the kidney, but also what's the impact on weight? What's the impact, how likely are the meds to cause side effects or hypoglycemia? What is their cost? And what does the patient, what's the patient willing to do? So we're going to think about all those things together to try to make good decisions. So let's start with this question. Which one of these meds would lower glucose and weight and have a low risk of hypoglycemia? B. That's correct. So sitagliptin is oral DPP-4. It does lower glucose. It does have a low risk of hypoglycemia, but it does not lead to weight loss. Semaglutide also is a correct answer. It does all of those things, GLP-1 agonist. Glyburide does lower glucose, but it increases weight. It increases the risk of hypoglycemia. And pioglitazone lowers glucose. It actually increases weight. It doesn't decrease it, but it does have a low risk of hypoglycemia. All right, which of these statements is true about cardiovascular outcome trials? Let me. Any ideas on that one? So yeah, across the board, like who knows? It's hard to keep up, right? There are a lot of cardiovascular outcome trials that have been published. But I think the correct answer here is A. So we've got different outcomes with different categories of meds. And the DPP-4 inhibitors, cardiovascular outcome trials have been done. They were not beneficial, but they were safe. So they don't cause harm, but they did not provide any benefit either. I think the other ones are wrong because it's just not all. So not every single GLP-1 had positive cardiovascular data. Not every single SGLT2 inhibitor had positive cardiovascular data. And not all of them looked at patients just with cardiovascular disease. Some looked at patients that just have increased risk as well, but don't actually have established disease. Okay, so we're going to get back to the cardiovascular data, but let's just start. So we're comparing and contrasting all of the diabetes medications. Let's start with how they work, what their physiologic action is. And to do that, let's just remind ourselves of all of the pathophysiology going on that leads to hyperglycemia. So of course, with type 2 diabetes, the underlying problem is insulin resistance. So you've got insulin resistance in the liver, in the muscle, in the fat, which just means your body's not responding to your own insulin as well. Your pancreas starts making extra insulin to get the job done. Most people that have type 2 diabetes have had pre-diabetes for a number of years. Their pancreas has been working overtime, cranking out more and more insulin to manage that glucose. And eventually the pancreas can't keep up. So you start to see beta cell failure, beta cell burnout, decreased. So you initially start with increased insulin secretion, and then you start to see petering out of insulin secretion by the time they get that diagnosis. So that's the underlying pathophysiology, is insulin resistance. You don't usually get the diagnosis of diabetes until you also see that reduction in insulin from the pancreas. Those two, that's the core patho that we all learned about in school. Since then, we've learned a lot of other things going on. Primarily in the GI tract, we have a reduction in GLP-1 secretion. So GLP is a gut hormone that responds to carbohydrate intake and tells the pancreas to make insulin. And it tells the pancreas to decrease inappropriate glucagon secretion as well. So remember, glucagon is that counter-regulatory hormone from insulin. So glucagon, insulin decreases blood glucagon increases blood glucose to maintain that sweet spot of 80 to 100. When you have type 2 diabetes, not only do you have a reduction in insulin secretion, but you also have extra glucagon coming out, which you don't need, right? When you're eating a big pasta meal, you don't need glucagon to tell your liver to make extra glucose, but that's one of the pathophysiologic defects. So one of the reasons that happens is because people with type 2 diabetes have a reduction in that gut hormone GLP-1. So the job of GLP-1 is to recognize this guy's eating a meal right now. I'm going to tell the pancreas to make insulin and not make glucagon. But people that have type 2 diabetes don't have that amount of GLP-1. So you don't get that correct secretion of insulin and the stopping of the glucagon. We also know that people with type 2 diabetes have an increased rate of glucose absorption. So the glucose gets into the system faster. The pancreas is a little more slow at secreting insulin. So you can get a lot of big bursts or rises in glucose quickly after meals. And then we know that there's stuff going on in the kidney. So I don't think we appreciated this for quite a long time, but the kidney also is responsible for some glucose production. Most of glucose production comes from the liver, but the kidney produces some glucose as well. And glucose also gets reabsorbed at the kidney, right? So people that don't have diabetes are not peeing glucose ever, unless their glucose levels in the bloodstream are really, really elevated. Why? Because the kidney is reabsorbing all of that glucose back into the system. When you have type 2 diabetes, you have an overexpression of this receptor SGLT, And that means that you're reabsorbing even more glucose than you typically would. So it's the body just trying to hold on to glucose no matter what when somebody has type 2 diabetes. So we know that there's a role of the kidney as well. So lots of different things going on from a pathophysiology standpoint. And we have medications that target all of those, most of those defects, not all of them. So of course, we've got sulfonylureas, the tried and true, that increase insulin secretion from the pancreas. They do it in kind of a archaic way because they do it in a way that doesn't matter what your glucose level is. Sulfonylureas are just going to say, make some insulin. Even if your blood sugar is 40, make some insulin. So kind of an old school way of secreting insulin from the pancreas. The GLP-1 receptor agonists and the DPP-4 inhibitors work at the gut by increasing GLP. We'll talk about the specifics in a little more detail in a couple slides. We've got metformin that primarily decreases glucose output from the liver. TZDs work primarily by increasing insulin sensitivity at the muscle. And then the SGLT2 inhibitors that work at the kidney to kind of decrease that reabsorption of glucose at the kidney so that you're peeing out some of that glucose to lower your blood glucose levels. And we'll talk about those specifics in more detail. But you can see it makes sense, combination therapy targeting different pathophysiologic defects makes sense for some of these combinations. One of the first things that I know I remember learning, like, which medication has the most impact on glucose. I'm going to use a sulfonylurea because it can lower A1C by 1 to 2%, whereas some other medication can only lower glucose or A1C by 0.5%. And we spent a lot of time like mulling over those numbers a lot. I think that's challenging because all of those studies were not comparing all the drugs to each other. It's like sulfonylurea studies were done decades ago when people were walking around with A1Cs of 12 in studies. And so it's much easier to lower a 12 down to 10 than it is to lower an 8 down to 6. So saying sulfonylureas are more effective because they lower A1C by 2% and these drugs only lower A1C by 1% is kind of comparing apples to oranges because they were done in different patient populations. So meta-analyses, on the other hand, have identified that typically when you start, definitely for second-line therapy, so say you put people on metformin and then you're looking at starting second-line therapy, there's not a huge amount of difference in terms of glucose lowering between all of the agents. There are some differences that have shown up, but they're not gigantic. So instead of thinking about numbers, I just think about high, intermediate, or low in terms of how they compare and contrast to each other. So we know that SGLT2 inhibitors and DPP4 inhibitors are not as effective compared to the other medications. So all the other medications are pretty darn good. DPP4 inhibitors and SGLT2 inhibitors are going to do a little less effective job at lowering glucose compared to the other medication classes. So let's just do a quick review of metformin, just to make sure we're all on the same page. Metformin has always been our tried and true first-line therapy. I will say that the American Diabetes Association guidelines this year is the first time they've said, well, maybe not anymore. That's been like coming down the road for many, many years. And it still says like generally metformin is first line, but not always anymore. There are going to be some times where different medications are going to be more important to use than metformin. But why has metformin been our tried and true for so long? Because it's real good and it's real safe and it's real cheap. So it's got a lot of great things going for it. So metformin is very good at lowering A1C. It typically works primarily on fasting glucose as opposed to postprandial. We have good experience with it. So if you guys remember, the UK PDS was the big landmark trial with type 2 diabetes that showed us the good glucose control reduces complications. And it wasn't comparing drug A to drug B. It was comparing intensive glucose control to normal glucose control at the time. But they did use metformin in that study. And that was a huge study. It was done for years. So we feel good that it was safe. We didn't see any crazy adverse effects pop up. And using metformin as one of the medications in that study showed good results. So we've got some evidence that supports its use, and we've got a lot of experience. We also know it has a low risk of causing hypoglycemia. So it tells the liver just to stop making extra glucose when you don't need it. So it's not impacting insulin secretion from the pancreas. So low risk of hypoglycemia. And it doesn't cause weight gain. It actually might cause a little bit of weight loss, not a ton, but a little. So that's also a big benefit. There is a dose response to metformin. So I see a fair amount of people that will be on 500 milligrams once a day, which does not have a huge impact on A1C. And it's not the recommended target dose. So the recommended target dose is 1,000 milligrams twice a day or 2,000 milligrams a day, because that is where you get the most A1C lowering. So I think if you're going to use it, use it. I think 500 milligrams a day does not really do a whole heck of a lot for glucose. And UKPDS showed that you get that benefit in long-term complications in folks that you start treating and get really good control right when they're diagnosed. So good control at the onset of diagnosis is what creates that legacy effect down the road. So in my mind, if you're going to start metformin, give them the full dose, get it on board, and get everything that you can out of it, because it's not like you can overshoot. You're not going to cause hypoglycemia with metformin. So get really good control, because it's going to help you down the road.
Do you treat pre-diabetes?
I do.
Besides with lifestyle?
Yeah, so pre-diabetes, so the diabetes prevention program looked at lifestyle versus metformin versus placebo in people that had pre-diabetes to see how effective it was at holding off the development of type 2. Lifestyle modification was twice as effective as metformin, but metformin was more effective than placebo. Metformin was actually not effective in every subgroup too. So it was mostly effective in younger people, so less than 60, that had very high BMIs, like over 40. So for me, for pre-diabetes, I don't start with metformin. I think lifestyle modification is absolutely the best way to prevent the development. But if you have somebody that is working on lifestyle and you see their A1C still creeping up, then I might add metformin onto it, especially if they're in those patient populations. So they're like 45, their BMI is 42. I know metformin is going to do a really good job there. Yeah. As we all know, the major side effect of metformin is diarrhea. It happens in a good percentage of people. So we need to make sure that we're talking to people and dosing it appropriately so that we're having the most likeliness of having it work and not causing a lot of side effects. We also know that long-term use increases the risk of vitamin B12 deficiency. So that means anyone that has been on metformin for 5 years or longer, you should start thinking about vitamin B12 and just checking a level to see if it needs to be replaced. Or anyone that has peripheral neuropathy, just like everybody, or not everybody, but a lot of people have peripheral neuropathy, but the B12 deficiency can actually increase that neuropathy. So if you've got a patient who's had diabetes for a while, they've been on metformin for a decade, they've got some peripheral neuropathy, like remind yourself, take a B12 just to check to see if it needs to be replaced. And then we used to be really concerned about lactic acidosis with metformin because fenformin had a really high risk. Metformin has a very low risk, and the prescribing information has changed over the maybe five or 10 years now it's been. So we're not as aggressive in terms of who can't take metformin based on kidney function. We'll allow some more people to be on it because we know now the risk of lactic acidosis is a lot lower. I just bring this up because the GI side effects are a really big deal, right? We've all had lots of patients who are like, I will never take metformin ever again, no matter what you say. Some of those people are legitimately folks that just cannot tolerate it. But a lot of those people too, if you dig a little deeper, you realize like somebody prescribed 1,000 twice a day right out of the gates, and they had diarrhea for 3 days and they hated it and they'll never take it again. You're like, oh, we could have worked on that. We could have maybe done a few things to try to mitigate that side effect. But the left here is the package insert for immediate release metformin. You see diarrhea rates were 53%. So a lot of people are going to get it. The extended release is much less. Now, granted, the placebo arms are a lot different too. So I'm sure it's the way in which they captured that data. But extended release, there may be some evidence that extended release can cause a little bit less diarrhea than the immediate release. So what do we do to try to mitigate diarrhea with metformin? We start with a low dose, 500 once a day, 500 twice a day. We tell people to take it with food. We increase the dose slowly over a couple of weeks to get to that standard dose. If they're not tolerating it, we back off. We titrate a little slower, or we switch to the extended release product to see if that works. The other thing that I do is I tell people this is short term for most people. It happens in the first week or two. It's worse than typically most people will get used to it, and the GI side effects lessen or go away completely over time. And if you give them that guidance up front, you're going to be more likely that they'll stick it out and try to get through those couple of weeks. Yeah. Okay. Yeah.
I have a question from his first.
Yeah.
And what she said is that she's got new diabetics diagnosed with A1C 7.4% with 1,000 milligrams of metformin causing hypoglycemia.
Yeah. So, did you guys all hear that okay? Yeah. So I would say I would ask the patient to really verify, is it symptomatic hypoglycemia or is it hypoglycemia that's confirmed? So a lot of people that have higher glucose levels, when you put them on a medication and their glucose level starts to come down, they feel bad, right? They feel like they're having hypoglycemia. They're symptomatically not feeling great. Because their body is used to living at a higher glucose level. So again, the rates of hypoglycemia with metformin are not zero, but they're very, very rare compared to other meds that increase insulin secretion from the pancreas. So when people tell me like, I'm getting a bunch of hypoglycemia from metformin, I'm like, well, tell me more about that. What are you feeling? When's it happening? Did you test your blood sugar when it happened? And we talk about, if you're feeling symptomatic, but your glucose is 84, metformin's not causing hypoglycemia. But that would be a reason if they're feeling symptomatically bad and they're on 1,000 milligrams of metformin, you leave them at 1,000, you don't push to 2,000 at that moment. But I would try to dig a little deeper with the patient. Okay, so there still are some times that you're not supposed to use metformin in kidney disease. It's just at a much lower amount. So if your eGFR or creatinine clearance is less than 30, no metformin. If you, this is the prescribing information that says if you're between 30 and 45, if you're already on metformin, you can leave the person on metformin, but you wouldn't start metformin in somebody in that category. So less than 30, absolute no. 30 to 45, if they're on it, they can stay on it. If you were going to start it, you probably don't start it. Anything above 45, metformin is fine. And the prescribing information doesn't say anything about dose reductions in certain categories. They just say yes or no. But there are some expert recommendations that kind of put people in this 30 to 45 category, they recommend using half of a half dose. So 500 twice a day or 1,000 once a day. So not everyone does that, but just so that you guys know, like that middle ground, some folks really believe you should only be using half of the dose. The prescribing information doesn't say that anymore. It says you can technically use the full dose. Okay, so lots of advantages of metformin. I think we covered most of them. It's oral, overall reasonably well tolerated, very inexpensive. We're totally used to using it, which is why it's been first line for so long. The diarrhea is a concern for some people. The renal dose considerations you got to keep in mind, and then that vitamin B12 is the other thing to keep in mind with metformin. Any questions about metformin? Any good stories? Yeah.
What is the benefit between the not extended release and the extended release? Because due to side effects, I tend to just go straight to the extended.
I think it's totally fine because extended release products are generic now. And so just starting off with extended release could be much easier as just a starting place. I think there are differences in some of the products. And so not all of them are super cheap. Like you just got to make sure you order the right one. And then the other thing sometimes patients complain to me about is the size of the tablets. So just as long as you're finding a size that works okay, I think starting with extended release is totally fine. Okay, let's talk about the SGLT2 inhibitors. So we've got 4 to choose from: canagliflozin, dapagliflozin, empagliflozin, and ertagliflozin. Ertagliflozin is the like me too sad, lonely stepchild of the 4 because it doesn't have any good data and nobody really uses it. And it was like last to market. But for completeness, I wanted to make sure that it was up there. Okay, so like I mentioned before, SGLT2 inhibitors inhibit glucose reabsorption. So we've got the SGLT2 receptor and then the SGLT1. 90% of glucose gets reabsorbed up here. And people that don't have diabetes, you don't get any glucose in the urine. The SGLT2 inhibitors block that receptor, so the glucose does not get reabsorbed. So you do get glucose in the urine. So we used to view like anyone that had glucose in the urine, that was bad, right? That was a sign that they had significant hyperglycemia, uncontrolled diabetes. And now we're utilizing it as a mechanism for medications. So you can get glucose loss anytime the blood sugar is elevated. So anytime the blood sugar is high, then you know those SGLT2 inhibitors are trying to increase glucose output in the urine. So what that means is you get better glucose control because you're losing glucose in the urine. When you're losing glucose in the urine, you're also losing calories. So it can lead to some weight loss as well. In terms of efficacy, these are medications that are, like I mentioned, are intermediate. So they're not the best, but they do lower glucose. So they get that intermediate category. One of the nice things is that their mechanism has nothing to do with insulin secretion. So it's going to work whether people have beta cells making insulin or not. So you're like, oh gosh, could we use it in type 1 patients? We can. It kind of helps like close the gap or make glucose less variable, but they did not receive FDA approval. One of the meds did go to the FDA to try to get approval for type 1, but the data from the FDA perspective was not compelling enough in their minds. And because of some side effect risks as well, which we'll talk about. So the weight loss is modest. It's not super great. But why are we seeing these used so frequently if they don't decrease insulin or glucose that well, if they're not super great for weight? We're seeing them because we're seeing a lot of other outcome data. So we've got really strong data that these medications not only lower blood sugar a bit, but they also reduce cardiovascular events, they help with heart failure, and they protect the kidneys. So lots of reasons to be using these meds. Okay, let's start with the cardiovascular outcome trials. So again, erdagliflozin doesn't make it on the list because it doesn't have a cardiovascular or positive outcome trial, but the other three do. So empagliflozin, the study was EMPA-REG outcome. That was the first one, which kind of blew our minds. So like, if you remember back, it was like 2008, we had all this hubbub about rosiglitazone. Do you guys remember this? Like, rosiglitazone increases cardiovascular events. Like, oh no, what are we doing? And it was really like an interesting thing because diabetes meds were getting approved by the FDA with these really like piddly little studies, like 24-week studies that showed a reduction in A1C, and that's it, which maybe wasn't enough time to see adverse effects, right? You don't need that many patients in a study to demonstrate a reduction in glucose. So like, we've got a couple studies, 24 weeks, a couple hundred patients. Ooh, we've got a new drug for diabetes. And people have always been worried about sulfonylureas increasing cardiovascular events. And so there was a study with rosiglitazone that showed people were having increased rates of cardiovascular events with rosiglitazone. And there was one doc in particular at Cleveland Clinic who was a big whistleblower. And he was like, this has got to stop. Like, we need to have more aggressive studies before we approve these drugs. And the FDA listened and said, you're right, we need to require that new diabetes drugs demonstrate cardiovascular safety before they can get approved. So from 2008 on, all of the new diabetes meds have these cardiovascular outcome trials that were designed not to show benefit, but to show safety. So they typically have a composite primary outcome, so, which we refer to as MACE, M-A-C-E, major adverse cardiovascular events, combination of non-fatal MI, non-fatal stroke, and cardiovascular death. So companies had to do these big cardiovascular outcome trials to demonstrate safety. Then EMPA-REG outcome comes along, and not only did they demonstrate safety, but they were like, oh my gosh, we showed benefit. Like, our drug decreased major adverse cardiovascular events. And now we've got, study after study to keep track of, because a lot more studies are now being done looking at outcome data. So with that history, EMPA-REG outcome was first. All of those patients had established cardiovascular disease at baseline to get into the trial. Some of them had heart failure, but not that many. You can see duration of diabetes was 10 plus years. Their A1Cs were not horrible, and they were not targeting glucose control. They're like empagliflozin versus placebo. Follow them for a couple of years, see how many people get cardiovascular events. We're not doing GLP. Canvas was with canagliflozin, Declare TIMI 58 was with dapagliflozin. Declare was interesting because they came third. So these two were published, showed benefit. The DAPA folks were like, well, let's try to increase our market, and let's also not just look at people with established cardiovascular disease, but let's also look at people that just have risk. If we can expand it to them, we've got a lot of people that we're talking about. So they had a lot more people that did not have established cardiovascular disease at baseline. And then this is what we saw. So for that major adverse cardiovascular event outcome, empagliflozin and canagliflozin were both positive. So they showed benefit with that composite outcome. They also, EMPA showed benefit with cardiovascular death, with all-cause mortality. DAPA was not successful with the MACE outcome, but they had this weird other outcome that was cardiovascular death plus hospitalizations for heart failure. And that one was statistically significant, but technically it was not significant for the major adverse cardiovascular events. And then we also saw this, which really got people thinking. All three of these trials, in terms of a secondary outcome, they showed a reduction in heart failure hospitalizations. So people were like, what's going on here? Is it just because it's a diuretic? Is it something else? Like, why are we seeing a reduction in heart failure hospitalizations with these meds? They also looked at other secondary outcomes, including stuff related to the kidney. So all of them are a little bit different. So these are secondary outcomes. It's not what the study was designed to do, but they still showed positive effects. Each of them looked at renal outcomes in a little bit of a different way. So there's lots of ways that you can evaluate if something is beneficial for the kidney. Is it like who had a doubling of creatinine, or who had an EGFR that declined by a certain amount? How many people ended up on dialysis? Things like that. So they're all like, it's kind of messy, I think, with kidney outcomes, but across the board, all three of the studies also showed that these medications were effective at preventing the progression of kidney disease. So like really remarkable trials: reduction in cardiovascular events, reduction in heart failure hospitalizations as a secondary endpoint, preventing the progression of kidney disease as a secondary endpoint. So from that, these companies were like, we got to get some more studies going, right? We need to do some primary studies for these other outcomes. So we need to be looking at these meds as with a primary outcome of kidney stuff, and then primary outcome of heart failure hospitalizations. So this was the first one that was published, and it was the Credence trial. It looked at canagliflozin, looking for renal outcomes, specifically in people with type 2 diabetes and nephropathy. So interesting to keep in mind. So again, this was not looking at glucose control. They didn't care what the glucose was at the end. These were people with a baseline A1C of around 8. They had diabetes for a long time. Most of them were on metformin, but not everyone. And this is 100%. Everyone had to be on an ACE inhibitor or ARB to get into the trial. They were like, will this help reduce cardiovascular chronic kidney disease in people who are already on standard of care? And then baseline GFR was about 56. So endpoints, positive. So everything in orange is statistically significant. So all of the kidney outcomes were positive. So they're like, this was the first, we've got ACE inhibitors and ARBs, and that's kind of it, right, in terms of protecting the kidney. So this was the first time where we had something that said, we have something to add to ACE inhibitors and ARBs that can prevent the progression of chronic kidney disease. The next study that was published was with dapagliflozin, and this study was great because it went even beyond people with type 2 diabetes. So it's like, let's see if these drugs can prevent the progression of kidney disease in people with or without type 2 diabetes. So about 68% of people had diabetes at baseline. Almost everybody, again, was on standard of care, so on an ACE inhibitor or an ARB. And baseline EGFR was in that 40s range as well. So let's keep in mind. So Credence, they were looking, so if you think back to that figure that had EGFR on one side and albuminuria on the other, where it goes from green down to red, you're thinking like, okay, where is this patient population where these meds might be used? So the Credence trial looked at people who had an EGFR of 30 to 90 and a UACR greater than 300. And then DAPA, a little bit lower. They went all the way to 25 for EGFR and crazy high albumin to creatinine ratios. So again, this isn't everybody. It's not just for people that have fine EGFRs. These are for people that have middle of the road GFRs and have albuminuria with or without diabetes. And this study was also positive. So it prevented the progression onto the more red boxes in that patient population. And then at the same time, they were doing studies looking at heart failure also. So DAPA-HF was the first study to come out. This was dapagliflozin in patients with heart failure with reduced ejection fractions. Again, not all of them had diabetes. So 40% of them had diabetes. So we are looking at these drugs being used for not just glucose control anymore, and not just for people with diabetes, but also for people just with chronic kidney disease or just with heart failure. This study was also positive. So they had this primary composite outcome of worsening heart failure or cardiovascular death. And across the board, for the primary outcome, it was positive, and also just those individual parts of the composite were positive. Huge. So dapagliflozin reduced heart failure hospitalizations in people with and without diabetes. And then the 2 studies with empagliflozin just got published as well. Again, this was with reduced ejection fraction with empagliflozin. And again, we saw a reduction in that primary endpoint. And then this year, published in the New England Journal, our minds were blown again because empagliflozin also showed positive outcomes in people with heart failure with preserved ejection fraction. And we don't have anything to treat those folks. So people that have diastolic dysfunction, we don't know what to do. Most of the treatment algorithms in terms of ACE inhibitors and beta blockers and all the standards that reduce cardiovascular events, all of those have been proven in people with reduced ejection fractions. And this study published in New England Journal this last year showed that empagliflozin reduced cardiovascular events in this population of people with preserved EFs. So that's really quite remarkable. So you think, well, why? How are they working to do all of these great things? Who knows? But there's a lot of ideas that include just osmotic diuresis, right? So glucose is you're peeing out glucose. Water is going to follow. It could simply be that, but we know there's a lot of other things going on in terms of just volume, decreasing volume overload, improving those metabolic parameters, reducing plasma volume, decreasing the stress of the left ventricle, lots of theoretical reasons why these medications are beneficial in all of these different aspects. So that's a lot of indications, right? So these meds basically are just not being used for glucose control. They are going to be used to reduce cardiovascular events. They are FDA approved for that. FDA approved for preventing the progression of chronic kidney disease, FDA approved for heart failure. And these will just continue to expand as they bring these drugs back to the FDA for new indications every time a study comes out. So empagliflozin is there now to try to get that FDA approval for preserved EF. They don't have it yet, but they probably will sometime this year. So I think then the other thing to think about, again, erdagliflozin doesn't have any data, so I don't think about that one very much. But otherwise, the cardiovascular events, CKD, heart failure, you're seeing benefit across the board for the most part. That dapagliflozin had kind of a weird primary endpoint. In my clinical practice, we actually don't have a strong preference for one versus the other. It seems like a class effect for the most part from what we've seen with the clinical trials. I think the one big thing to keep in mind with these is the kidney issue. So you're like, these are drugs that help the kidney, but you also have kidney limits of when you can use them and what the doses should be. And that is just hard to keep track of. So like dapagliflozin, you don't start if the eGFR is below 25. Empagliflozin, not recommended if the eGFR is less than 45, which is weird because, well, their kidney trial is ongoing. But once they get that kidney trial done, which will go to a lower eGFR, that will probably change. So that kind of stuff, I think, is challenging to keep track of in terms of when you can use them and when you can't. But bottom line, I think it's very important to remember this bolded line right here, which is we're using these drugs at an eGFR all the way down to 25 for outcomes. So to protect the kidney, to reduce cardiovascular events, to reduce heart failure. But if your eGFR is below 45, it's not really doing anything for glucose. So it stops having that glucose in the urine effect once your eGFR is below 45. So that's also weird, because if you have someone who has an A1C of 8 and you're like, I need to start another medication for diabetes, and oh, this person has kidney disease, so I want to pick an SGLT2 inhibitor to also protect their kidney, it is going to still work to protect their kidney, but it's not really going to do anything for your glucose. So that, I think that's just an important thing to keep in mind for that weird renal dose cutoff.
So do you pull them off of it if it goes below 25?
Yes. So if it goes below 25, you are supposed to stop it. Yeah. Let's see what the, okay, I'm going to be done with SGLT2 inhibitors and we'll take a break. So side effects are another thing we got to think about with this class of medications. The number one side effect that we see are yeast infections, which is which makes sense, right? If you're peeing out glucose, your increased risk of genital mycotic infections and UTIs increases. The risk of UTIs is actually, I think, pretty darn low, surprisingly, but the yeast infections definitely an issue. More common in women, but men can also get it too. So what do you do about this? So the first time somebody gets a yeast infection, you give them treatment or tell them to go to the pharmacy and get an over-the-counter treatment. You don't have to stop the SGLT2 inhibitor. In our clinic, we're like 3 shots and you're out. Like, so we'll go through that process 3 times. If they've had 3 yeast infections, it's like, okay, you're not going to take an SGLT2 inhibitor anymore. Because you're just going to keep you're going to be someone who just keeps getting routine yeast infections, which you don't want to give somebody a medication that's going to cause repeated side effects. So that's what we do in our clinic. Everybody does something different, but the clinical trials, most people got 1 yeast infection. It was treated. They didn't have to stop the SGLT2 inhibitor and they were fine after that. So that's just what is reported in the trials. And the other big thing that we talk about is just good hygiene. So if you have good hygiene and you stay well hydrated, that's the best thing that you can do to prevent yeast infections.
Are you saying 3 just in general or 3 over a certain amount of time?
Yeah. I think some clinics will say, if you've had 3 yeast infections in a year, then we're going to stop. I have very, very few patients that have had 3, but if they have had 3, they're saying, I'm not going to take this anymore. Yeah, but it's not actually that many. I have a fair number of people that have had 1, but that's it. And maybe they're not reporting as well, but that's my experience with it. Yeah. Okay, so the other thing to think about is just this volume issue. So you want to make sure that people are staying well hydrated. There's some increased risk of dizziness or orthostatic hypotension. Those rates also in the clinical trials are quite low, like lower than what I would have thought and what I was initially concerned with. But I just make sure you tell people, like, make sure you're staying hydrated. Make sure you're standing up slowly initially just to see how this drug is affecting you, but most people do okay with that. There are some more serious concerning side effects to keep in mind with this category of meds. Diabetic ketoacidosis, some evidence of amputations, fractures, and Fournier's gangrene. So I think I have 2 slides on the top 2, but not on the last 2. So the fracture issue is actually not really a concern for me anymore. That came from the canagliflozin studies early on, and they saw this mild increase in fracture rates. And digging a little bit more deep into that side effect, they found that most of the fractures occurred within the first 6 to 12 weeks, which makes you think, okay, this is not bone mineral density related because it's just too soon for that to happen. And most of them happened in the wrist. So in those early trials with Canna, they put people on the highest dose immediately, and they didn't have really great education about volume. And so they think it was really people were just getting dizzy and falling and breaking their wrists. So I think with good education and good volume stuff, it's not the hugest concern, and it's definitely not related to bone mineral density. So that's good to know. And then the Fournier's gangrene was also seen in some of the large outcome trials. These are very small cases. So this is not like, these are very rare, right? So again, personal hygiene, thinking about your patient population is important there. The first two, though, I think are worth mentioning. So you may have heard about this euglycemic DKA with SGLT2 inhibitors. So when the SGLT2 inhibitor is working on that receptor and blocking glucose reabsorption, you end up getting this mild ketosis. So it's like if you're on a no carb keto diet and you kind of live in this mild ketotic space, it's not harmful to you. But if you're already having a little bit of ketosis, if there's anything that would increase your risk of DKA, you're already partially there. So keeping that in mind. So who's at risk for DKA? These are people that require exogenous insulin. So they're not making any of their own insulin. They stop taking their insulin, or their insulin needs go up, right? They're sick or something like that. That's who's at risk for developing DKA. So the risk of DKA with SGLT2 inhibitors is increased in those patients, which is certainly not everyone that has type 2 diabetes. But if you had a person with type 2 diabetes that also requires exogenous insulin because they're not really making any on their own, and then they don't take it, then you put them at an increased risk of DKA. The reason it's concerning with SGLT2 inhibitors is because they still work even, regardless of insulin status. So typically, how do you identify somebody with DKA? They have ketones, but they have very extreme hyperglycemia. And with SGLT2 inhibitors, the glucose levels can still be normal, or not normal, but not greater than 250, because the SGLT2 inhibitor is still working. So I think that's the concern with DKA with these meds, is that it's harder to identify because the glucose levels aren't really high. That's a long-winded story, but this is not a huge issue for most people with SGLT2 inhibitors. If you have somebody who you want to start an SGLT2 inhibitor, and you also know they're not making any of their own insulin. So they're a type 2 that's had diabetes for 30 years. They're not making insulin anymore. They're on basal bolus insulin. Those are people you're like, I can still start an SGLT2 inhibitor, but I need to make sure they know you always have to take your basal insulin. Your body doesn't make any insulin. So you always have to take your insulin, or you can end up with diabetic ketoacidosis. So you need to educate them, and you need to tell them, because this drug over here is going to make you more prone to that because you're already living in that mild ketotic state. So that's not a ton of patients, but it is a certain patient population to keep in mind. And then the amputations, there was some evidence suggesting an increased risk of amputations with SGLT2 inhibitors as well. Again, the risk was very, very low. So the absolute numbers are very low, but we did see it in a clinical trial. What's the rationale? There was a study many decades ago showing that hydrochlorothiazide also increased the risk of amputations. So is it just volume related? So if you have somebody with peripheral vascular disease and they're at risk for some type of peripheral neuropathy or diabetic foot infection or something like that, and then you make them a little bit volume depleted, then they're getting less blood flow. Maybe that explains it. Again, the rates were very, very low, but I do keep it in mind just in terms of, like, if I'm seeing a patient that already has established peripheral vascular disease or who has a previous amputation, that's going to cross my mind, this potential risk. serious but rare. Okay, so hopefully we covered all of these things. So a lot of advantages. Glucose lowering is not really one of them. I mean, it does lower glucose, but that's not the big reason why we're using these meds. Instead, we're using them for all of those other outcomes. And there are some things just to keep in mind in terms of eGFR and side effects and things like that. But they are oral, they are once a day, so they're easy to take and easy to add on. Okay, any questions about SGLT2 inhibitors? It was a lot. They're the ones with not every category will take this long to get through, but these do because they got all the good evidence. Yeah.
As a pharmacist, which one gets best coverage in general?
Actually, I think they're pretty good. So like for a long time for Colorado, we were using empagliflozin primarily because Colorado Medicaid was covering it. But now Colorado Medicaid's covering all three. So, you know, we like which one's your company covering, and that's the one we write for.
I had patients come and wanted to be taken off when that study came out.
Yeah. I mean, there was a lot of hubbub about it for sure. And it was this is a new category of meds. And so, I mean, I know I was super nervous and hesitant about the volume stuff, and we don't really know what it's doing to the kidney. And then these things came out with amputations and fractures and all these other things. And I was like, see, we don't know, like I was really a nervous Nelly with these medications. And the good thing is with these other studies that have like 50% of people with diabetes, and they're looking at other outcomes, not just glucose, the safety profile in those studies looks real good. Like DKA rates are non-existent, amputations not there. We typically use the lower dose. So like with empagliflozin, you don't have to go up to the high dose for any of those outcomes. You stick with the low dose. So maybe that's a little better from a safety perspective, but we're going to see these meds as non-diabetes meds for sure. And then the glucose lowering will be like a added bonus if you need it.